National Newborn Week, we have celebrated with a lot of gusto, and we had many celebrations at various hospitals in different parts of Maharashtra. So the theme for this year's National Newborn Week is that home care of newborns in urban areas. So they are trying to focus more on early skin to skin contact, clean delivery practices, vaccination. So basically prevention of disease in the first month of life. So a newborn is like from 0 to 28 days. And as the statistics and data from WHO show that most of the mortality takes place in this 30 days, within these 28 days. So we want to decrease this neonatal mortality. So as more number of people get aware about this program, and they know what are the burdens and challenges, this will help in reducing neonatal mortality and morbidity. So we also are we had a prematurity awareness week, which was celebrated on 17th of November, which was 17th of November, which was also the theme this time was that that parental embrace is a powerful therapy, and they advocate trying to promote skin to skin contact from the moment of birth. So this was also celebrated on 17th of November. So we have been having senior neonatologists all across Maharashtra to give talks on this neonatal celebration week. So similarly, today we have Dr. Dattatray Kulkarni, who is a DNB neonatology from Fernandez Hospital, Hyderabad, and is currently a consultant neonatologist at Vithai Hospital, Latur, as well as he's associate professor in the Department of Pediatrics, and he's NICU in charge in MISR College, and as well as YCR College in Latur. So he has received various awards for the best research paper. He has also won the Professor Dr. Meherban Singh Research Award at Neocon in Bangalore. He is an author for one of the textbook of clinical neonatology. He has publications in neonatology, and he is also a trainer for basic and advanced NRP. So with this background, sir is going to also has a special interest in nutrition and quality improvement programs. So considering his special interest today, will update us about the nutrition of premature babies. And so I welcome you, sir, and the stage is all yours. So you can share your presentation, and then we can start the presentation.
At the beginning, I would like to thank Rishi Thakre sir and Ashish sir for inviting me to talk on this topic, preterm nutrition. So, overview of my presentation will be, can we consider this preterm nutrition is like a nutritional emergency? What are the goals of preterm nutrition? What are the different phases of preterm nutrition? And first component is parental nutrition. What are different challenges and various solutions on that? Followed by enteral nutrition. What are the challenges and what are the feasible solutions to provide the enteral nutrition? And then what we are going to monitor while providing this nutrition, and how we can tackle the common causes of growth failures, followed by a 10 feasible steps of nutrition bundle. So like if the baby is born preterm, so we are having mindset that baby is going to be land up in respiratory emergencies, so we keep ready the delivery room CPAP, then surfactant. So we will prepare with a mindset and have a respiratory management plan. So we still, till the time we don't have this mindset that a preterm birth is like a nutritional emergency, so we have to prepare a nutritional plan for any baby born preterm, particularly extreme premature sequelae who are born preterm. So the lesser the gestation age, more will be the sequelae. Like in brain, they will have lesser brain volume, they will have higher neurological disabilities. Heart wise, they have more hypertension, or what we say early hypertension. Then they have reduced ventricular size and volume. They had impaired systolic functions. So coming to the bone, they may have low bone marrow densities, and there are other social disabilities, commonly autism spectrum disorders. So they had a definite developmental sequelae. And with this context, if you don't provide adequate nutrition, they are going to land up in very relevant clinical morbidities and mortalities that are going to happen in a NICU course of a baby. So that can be a metabolic disturbances like hypoglycemia, or hyperglycemia, sepsis, early as well as late onset sepsis, necrotizing enterocolitis, as well as weaker bone, the osteopenia of prematurity, then retinopathy of prematurity. Then they have lesser head size as well as psychomotor and mental skill issues as well as autism. So to keep in mind that we have to consider preterm birth is a nutritional emergency, and we have to plan it. So in a, if I will intact survival with not much neurodevelopmental impairment, specifically in a preterm babies, very preterm and very low birth weight babies. So component of different nutrition like adequate amino acids may decrease BPDs, increase growth, providing long chain fatty acids. DHA may have role in BPD and retinopathy of prematurity. Mother own milk has a role in NAC, definite role in NAC, as well as other effect on other morbidities like sepsis. So there is a definite role of optimal nutrition. So with this background, we can control or decreases the most of the morbidity and lead to a good survival. So what will be the goals of our preterm nutrition will be to achieve optimal growth centile, and the baby should not have or lesser postnatal growth failure. So whenever we want to achieve this, we have to supply a nutrient in a continuity after the birth, as well as our growth should resemble the fetal growth. So most of the time it is used as aggressive nutrition, but rather it is a misnomer. So aggressive means it is not a good word to say. So rather we should use the terms optimum nutrition in the place of aggressive nutrition. So to understand this, so that there is no where any fetal. On the right side there is a postnatal growth. If you look at the chart, there is a definite dip in a weight chart, as well as lesser the baby, lesser the weight, particularly ELW, there is a more dip in the weight centile, and it will take more time to take up. So to understand this, I have uh, uh, charted one baby's hypothetical baby's growth centile. So this baby born 27 weeker with 700 grammer. So this baby is at now it is almost now for 6 week, that represented by dotted line. So this baby is showing postnatal growth failure. So this baby should be in a matching the fetal growth centile. So to achieve this, so how the fetal will grow, we can if the baby is born preterm and extreme low birth weight or very low birth weight, how we can match the fetal growth. So we don't want wasting, we don't want stunting, and we want to have a good brain, good bones, good eyes, and good lungs. So while providing optimum, we should not optimum nutrition, we should not do a overdo. So we should have a good control over the speed of or what the amount we are giving. So that's why the word is optimum. If you overdo, there may be a problem for heart as well as metabolic. So there will be less metabolic support, and the coronary artery disease, early hypertension, obesity will be there. So that is called tryptophan phenotype or optimum days. So we have to start on total parental nutrition on day one itself. So first IV fluid of a baby should contain amino acid, preferably 2 gram per kg per day. So lipid we have to start by 24 hours, at least 1.5 to 2 gram per kg per day. So that we have to continue till the baby reaches 100 ml per kg per day of enteral nutrition. So what we understand by early aggressive enteral nutrition, the baby should receive the colostrum as early as possible after the birth, and baby should preferably get the mother own milk. And as the enteral nutrition advances, the baby should be fortified timely. That's what we call a early aggressive optimum nutrition by definition. So how early aggressive nutrition will result in a good outcome? So this is a systemic review meta-analysis where early parenteral nutrition has resulted in a good short-term growth outcomes. So diamond on a favoring side, and there was not much increase in a morbidity as well as mortality. So coming to most of, we had a fear that providing sepsis or there will be more death. So this is again a systemic review meta-analysis where they have shown that if you provide early lipid administration, it is safe. It doesn't resulted into a neonatal death. So moving forward, there are phases of nutritional support. First is a parenteral nutrition. So we have to start on parenteral nutrition on day one. So, and enteral nutrition, we have to minimal enteral nutrition, we have to start by gut priming. So here is a parenteral nutrition. Then second is a transition phase where we have to progressively increase the feeding volume and with a good milk, that is mother own milk or human milk, followed by weaning and stoppage of parenteral nutrition and full enteral feed. So these will be the phases of nutritional support for a NICU graduate. So what are the different recommended dietary intake? As per ISFGAN, calorie requirement will be 110 to 135 kilocalorie. Protein should be provided 3.5 to 4 gram per kg. Lipid should be 4.8 to 6.6. Carbohydrate should be 11.6 to 13.2. So these are the macronutrient. Vitamins importance are vitamin A in a 330 to 3000, vitamin D 800 to 1000, particularly in a very preterm babies. Then the various micronutrient like calcium, phosphorus will be in 1:2 ratios, then iron 2 to 3 mg per kg per day. So these are the recommended intake. So a few concepts we have to understand is initial recommended intake can be achieved by parenteral nutrition. Once there is a weaning of this parental aggressive optimum parental nutrition start, the baby will be on almost enteral feed. At that time, if you look at the various content of nutrient, macro and micronutrient, if the baby is on majority enteral feed, they may lack the protein, they may lack vitamin A, vitamin D, then micronutrient like calcium, phosphorus, and iron. So this we have to take in account. So when the baby is on full enteral feed, so that's why the importance of fortification. So coming to first phase, that is early aggressive parenteral nutrition. There are different types, peripheral as well as central or total or partial. When we say total means we are providing each and every component like lipid infusion, amino acid infusion. Partial means only amino acid we are providing. So coming to central and peripheral will be very high osmolarity. Osmolarity of fluid, if is there, we can't give to the peripheral route. but we can safely give the lipid infusion, amino acid infusion from peripheral IV cannula. But we cannot support the growth by providing this for long period. But the advantage is there is a lower risk of infection. So this will be very important in the context that if the baby is not ELW, so in that baby, if you go for aggressive enteral nutrition early, we can safely provide the peripheral aggressive nutrition by peripheral cannula. So central route is we can give higher osmolar fluid, and a nutritional need can be provided. So if the baby is needing parenteral nutrition for more than 7 days, suppose the baby is in a clinical scenario like NEC, then we need a central access only. So, but there are chances of CLABSI, that is central line associated bloodstream infection, if we are going for the central route. So what are the different indication? So the babies, if there is a extreme premature or extreme low birth weight, it is universal. We have to provide it. What we are talking at total parental nutrition. If the babies is less than 32 weeks, that is very preterm and very low birth weight and unlikely to achieve the enteral feed by day 3, we can provide. If the babies is more than 32 week or non-VLW baby, but unlikely to achieve at least 50% of feed by day 5, we can start. If there are surgical indications like necrotizing enterocolitis or other congenital anomalies operated for GI anomalies like this, we can need a total parental nutrition. So first component is carbohydrate. So in a fetal life, there is a continuous supply of almost 7 gram per kg per day from the placenta. So most of the the basal the residual glucose rate may be requirement may be 2 milligram per kg per minute, but that may not be sufficient for preterm babies because it's growing, so it may ranges from 6 to 8 also sometimes. And one thing we have to understand is if the preterm baby is an AGA, the resting glucose oxidation may not be very high. So we can, if the sugars are normal, we can safely provide 6 to 8. We need not go to higher glucose infusion like more than 8 milligram per clinical concept we have to take in account. So there should not be more pumping of carbohydrate. So if you pump more carbohydrate, there will be liver deposition of fat, and there will be enhanced production of VLDL triglyceride. So there will be increased CO2 production. There will be impaired protein metabolism. So that's why we have to keep a tight control on what glucose infusion we are providing. So second is an amino acid component. So in that, what is important is essential, we have to provide it, but all amino acid preparation practically available may not have the conditionally essential amino acids like typically cysteine or glycine, tyrosine. So then there is a fear that if you provide early aggressive amino acid infusion, does it really helps or does it really safe? So for safety, yes, it has a safe, doesn't related in aggressive renal compromise or acidosis, and there is enough short-term gain, particularly a weight centile and head centile growth will be there evidence wise. So aggressive amino acid drip is essential. It should be a first drip. So these are different formulations available. If you look at the amino, which is commonly available, most of the NICU uses aminomin 10%. So you look at the here, so that are conditionally essential like cysteine and glutamine may not be will be present in amino acid. So this is very relevant if you are giving for total parental nutrition for more than 2 weeks and there is no enteral feed, then we have to take in account while customizing the total parental nutrition. But when it is supplemented by progressive increasing enteral nutrition, it may not be relevant. So coming to the lipids, it provides most of the non-protein calories, and it provides essential fatty acid that is very important for brain growth. And one thing we have to understand is what kind of lipid we are giving to the baby is very important. So there are different generations of lipid emulsions. The first generation were mostly on uh, mm, soya oil, and the second generations they are combining with MCT, and more than 50% we are having MCT with olive oil and fish oil added. And third generations are mostly omega-3 based. So presently in India, the SMOP, that is second generation lipid emulsions are there. So these are quite safely resulted in a lesser sepsis. So and comparing 10% versus 20% and SMOP, there are lesser lipoprotein X and its hydrolysis products will be there. So that we have to take in consideration. So we have to give in aluminum foil, because if it is exposed, it may result in peroxidation, free radical administration. So, and what are commercially available, this they may not have vitamin E preparation with it. So we need to supply multivitamin preparation along with lipid to complement it. So one clinical concept may be relevant, we have to take into consideration is changes in a lipid profile. So in a first week, the both DHA and arachidonic acid decreases significantly, and the linoleic acid increases. So once this deficit of DHA and A increases, if you don't provide the essential fatty acid, then this deficit may not be corrected if it is timely not given. So a clinical significant amount of time will be lapsed to again there will be the deficit. It may take time. And coming about the evidence, there is a clinical benefit seen with adequate intake of long chain polyunsaturated fatty acid. There are lesser BPDs and retinopathy of prematurity needing corrections as well as cholestasis. So this is very important to understand that the early lipid infusion as well as early mother own milk intake by the baby to provide the essential fatty acids. So SMOP available is contains this SMOP only we are using. Intralipid, most of the units are not using. So it contains significant amount, but that may not be sufficient. The essential like DHA and arachidonic acid content is very less, but vitamin E content and tocopherol are much lesser. So coming to 10%, 20% in SMOP, here SMOP is a winner, and it has in a pediatric unit, if you are providing SMOP, it has resulted in lesser sepsis and lesser cholestasis. But the evidence in neonate is still not there. But more evidence is needed to recommend completely the SMOP for lipid as a lipid choice at this point of time. So coming to the different minerals, the sodium requirement in first week of life may be lesser, but beyond first week, the sodium requirement is very important to prevent the hyponatremia of prematurity. So initially the GFR is very low, so serum phosphorus may not be needed in initial 5 to 7 days, but later on it is very much needed to prevent the OOP. So suppose the mother has received magnesium therapy, the baby may have more magnesium. So that clinical list is very important while we are taking, particularly mother having PIH and other things. Coming to the vitamins, the separate water soluble and fat soluble vitamin solutions are not available presently in India. So vitamin provision dose will be 1.5 ml per kg per day. So what we are giving IV root vitamin D, it may be photodegraded, and some vitamins like vitamin A and D may stick to the tubings and all. So there will be losses. So vitamin K we have to give it separately. It is very important apart from birth doses. Vitamin B12 is not present in commercially available multivitamin, but the deficiency of vitamin B12 is very rare in neonatal age group. So coming to the trace element, so zinc is universally needed from day one of TPN, and the other trace element like copper, chromium, manganese, selenium, they may be needed if the baby is on total parental nutrition for more than 2 weeks, particularly in low birth weight input. So what we are monitoring while we are providing this total parental nutrition is we have to say fluid requirement, what is the fluid for today's total parental nutrition, then protein we are providing gram per kg per day, then lipid gram per kg per day daily, then what GR we are providing, then protein calorie ratio we can calculate from the calories and protein babies given, then GRBS monitoring preferably in a shift, in a first week each shift, then daily we can check, then serum electrolyte and calcium till the full TPN we need daily. Weekly parameters we can check the triglyceride, liver function test, PCV, creatinine and blood urea nitrogen. For like blood urea BUN values we can see whether the to knowing the adequate protein intake is received by the baby or not. So less than 10 is lesser protein intake. So nothing is foolproof. If you are providing this total parental nutrition, there are going to be side effect, but this side effect can be tackled off if we had beforehand we are monitoring it. So suppose the complication is like parental nutrition associated liver disease. So liver lipid like SMOP has lesser chances of having PNALD, that is a cholestasis. It will present with a cholestatic like thing, and either we can so there is no need of restriction of proteins for liver disease associated. So we can restrict the lipid, but replacing the lipid with other is not recommended at this point of time, but SMOP is relatively safe as evidence from the pediatric nutritional studies. So regarding the line related things with a laminar flow and avoidance of central line by keeping PIC line and providing this insertion bundle and maintenance bundle to take care of the line in a aseptic way, we can prevent the line related sepsis. And then there is a specific nutrition related complications, like if there is a lipid for that, in the if there is a hyperlipidemia we can decrease the amount. If there is a neonatal jaundice or very high jaundice or near exchange zone, we can restrict the lipid. Then for protein we can monitor the metabolic, any significant metabolic acidosis or blood urea nitrogen creatinine. And similar way for most important point in total parental nutrition is when we have to start weaning and what is the end point. So once the baby reaches 50 ml per kg of 15 ml per kg per day of enteral feed, we can safely wean the TPN. So and end point will be if the baby reaches 100 ml per kg per day of feed, so almost reaching full feed, we can safely stop the TPN to avoid these complications. So complication can be easily handled, and it is relatively safe to provide both lipid and amino acid. So that is the whole about total parental nutrition. So coming to the enteral nutrition, so this is milk, the feeding ladder. The best one is mother own milk, that to be fresh. The second will be donated fresh preterm milk, and third will be donated pasteurized donor human milk. So this is a feeding ladder. So which milk is best, whether it is a pasteurized human donor milk or mother own milk? So in that, the mother own milk is gestation age specific. 26-week mother milk composition may be different from 32, 34-week of gestation. So it is a gestation age specific. It may be mother baby specific. So it may be specific for given baby. So it has ethnic component also, and it is a dynamic. So the composition changes from morning, afternoon, and evening. So, and it is a lively fluid. So it contains the important bioactive factors. So with this context, if you consider pasteurized human donor milk, it has a process like pasteurization. Then there are freeze thaw cycles. Then switching of the milk bottles. Then we have to uh, store it. It may not be given immediately when it is collected and pasteurized. So there will be chemical composition change will be there, and there is a depletion of bioactive factor. And most important point is the microbiota. Means if you are providing milk, the gut bacteria may be different if you provide with a mother own milk and if it is a pasteurized human donor milk. And another thing is it pasteurized human donor milk may be a typically term milk produced in a different environment. So that we have to take into consideration. So we are worried with a necrotizing enterocolits. That is a dreaded complication with much more mortality with a choice of milk. If the choice of milk is mother own milk, choice milk is pasteurized human donor milk, it is good. If it is a preterm formula, there is an increased risk of uh, NEC. So interesting point is, and practically there may be a mixed feeding. So here, if it is a mixed feeding versus human milk, still there is a decrease in NAC. So we have to get at least human donor milk pasteurized if we don't have mother own milk. That's why there is a new surge in establishment of human milk donor bank everywhere. So, and particularly every district and every medical college should have the human milk donor bank. So that is the new things happening in a presently related to a pasteurized human donor milk. So coming to what we are interested in, clinically relevant outcomes. So compared to pasteurized donor human milk, head-to-head comparison, we can't do this head-to-head comparison study or RCT because it is an ethical issue. So we had a huge data, mostly on large observational studies. So where they had proven that the neurodevelopmental impairment, the BPD, and then ROP is less. So in these and sepsis also. So these four mortalities, the pasteurized human milk may not have any effect, but NEC, yes, death may not have. So the conclusion of this slide is the pasteurized human milk is best to provide to decrease the NEC to ensure the growth, but rest clinically relevant all morbidities will be decreased with mother milk. That is the superiority of mother own milk, and RCT is not possible because of the ethical purpose. So enteral nutrition, when we can start, like in parenteral nutrition, we have to start on first hour itself. So the baby should get the colostrum as early as possible, and the baby should get a minimal enteral nutrition, that is 10 to 15 ml per kg per day. So what will be the feeding and advancement rate? So there is enough evidence where they had compared 15 to 20 ml versus 30 to 35 ml per kg So they had seen that with rapid advancement, like 30 to 35 ml per kg, there was no increase in necrotizing interval. It is no increase in mortality. So it is a safe to increase the rate. Rapid advancement is safe. So there is a SIFT trial also, which is a good number. 2000. It is a NEGM trial published in NEGM. 2,800 babies. There was no difference in surgical NAC in late onset sepsis. One trial from India, that is from Sushma Nangia ma'am's unit from Delhi, where the stable VA, very low birth weight babies, they had started on total enteral nutrition from day one. They also noticed that there is a less sepsis as well as less. They reached early full feed, and there was a less incidence of sepsis as well as NAC. So it is a, so bottom line is the rapid advancement is safe, provided it is a good milk, that is mother own milk or pasteurized human donor milk. So maximum feeding volume we can safely reach is up to 200 also. And sometimes 200 ml is used in some studies as a growth investment strategy if the baby is not getting weight, gaining weight. So it is a safe if the baby is on mother own milk or human milk up to go up to 200 ml per kg per day, 3 hourly or 2 hourly depending upon the unit protocol. So coming to how much amount of milk we are given to the baby in a NICU stay. So every 10% increase in a mother own milk decreases NAC by 17%. So number needed to treat is 12. If you treat 12 babies, it will be one decrease in a surgical NAC. And low, so other dose dependent action of this human milk is seen on cost of care also. So they are Western data, but it has seen that cost of care is reduced. So, but there is a beyond that, there is a possible effect of on sepsis, retinopathy of prematurity, and IQ score also. So till the time we understood that it has a dose dependent action, mother own milk. So there is enough evidence on that, on the factors which lead to decreased uses is mostly that there is no proper initiation of lactation, and there is no lactation support given to the VLW mothers, and there is a less access to hospital grade pump. And there is a on Western spin, chalk, rush mother clean. These are inspirational lactational support work done by them. So I would like to quote one of my study here from my own unit at Hyderabad. So what we had noticed, we had studied almost 90 babies. So the mother who are visiting early, mother who are expressing at least 8 times a day, particularly night expressions, and electronic pump available has really has resulted in a much more mother own milk provided by mother to given to her or his infant. So coming to indication is at least the babies reaching 100 ml per kg per day, we can safely start the fortification. So there are different fortification method. So one is standard, second is adjusted and targeted. What do we understand by standard? We have to add the fixed amount of fortify to fixed amount of milk. So that is practically easy to understand, but still there is a possibility that we are providing less protein, we are providing less vitamins. So second comes the adjustable. So that is the most practically relevant fortification method, where we are what we are doing is monitoring blood urea nitrogen. So normal level will be 10 to 16, and if the level is less than 10, we are adding more HMF. So it is a real individualized method of fortification. So third targeted, where the milk provided to the baby is analyzed. So with a human milk analyzer, so all micronutrient can be seen and then can be supplemented. So So the levels is as per the population norms. So it is a very difficult in a real day-to-day life practical scenario, and it is a labor intensive. So conclusion from this slide is adjustable fortification is a kind of individualized fortification where we monitor for the protein adequacy. That is most practically relevant fortification method. So why it is needed? Like we previously discussed, if the baby is on full EPM, like that is 180 ml per kg per day, still the baby is lacking. That there is a need of this fortification. So these are three commonly available fortifier. Evidence wise, both are mother own milk may have added advantage over that, but uh, still the evidence needs for robust evidence needed to give a final conclusion on this. At this point of time, the mother own milk fortifier means a fortifier which is prepared from human milk, and lactose is prepared from bovine milk. So bovine milk fortifier has a lesser cost and easily availability, and the mother own milk fortifier is cost issues is there, and there are other vitamins also, vitamins as well as minerals are lesser in that. So clinically relevant morbidities may be lesser with mother own milk fortifier, but more evidence needed. So final line is depending upon the clinical scenario and what kind of milk available in your unit and cost involved. So we can take a decision. Both are at this point of time, both are same, bovine as well as mother own milk derived fortifiers. So then comes the feed intolerance. So for that, we have to understand what is a true feed intolerance. So what is a gastric aspirate volume? What is a color? Whether it is a really green or yellow or altered? What is abdominal girth? And is there visible bowel palpable loops? So when we can say it is a very much likely feed intolerance, if the bile vomiting, if it is a large hemorrhagic aspirate, or if there is a tense abdominal distension, then only it is very likely. Otherwise, if we have to clinically monitor if the in a high risk baby like Doppler compromise, or the babies having sepsis, in this high risk babies we can check if the baby is reaching 5 ml of feed, and we can in that baby a regular checking is needed. But otherwise, if there is a not much background risk of having NEC at risk, the may not be needed frequent gastric aspirate checking. So um, routine versus when needed, both are same evidence wise, both are same. uh, Routine checking of has not resulted in any decrease NEC or clinically relevant morbidities. So practical solution is we have to identify the true feed intolerance, and the you we can use smallest syringe for aspiration, and after the feed for prone then we can aspirate. So while providing this adequate parenteral and enteral nutrition, so growth we have to monitor. So the weight gain should be at least 10 to 15 gram per kg per day. Length gain should be 0.75 to 1 centimeter per week. The head growth should be 0.75 centimeter per week. So we have to choose a right growth chart also while monitoring growth. So serial measurement, that is the growth velocity, is very important to know the actual growth rather than the frequent rather than the only cross sectional checking. So what are the different possible postnatal growth failure causes? So the baby may not have adequate milk intake, so there may be increased expenditure like if there's a baby having morbidity like BPD, RDS, so or sepsis, there is increased requirement. So there may be baby may be in a cold stress, so lesser KMC duration. The baby is not taking care of optimum temperature, or there may be frequent losses like GR, vomiting, diarrhea, or other endocrine causes. So we have to sit with a mother, the how the milk is expressed, how much milk volume is given, how the fortification is given. So optimum for milk volume, then optimum fortification, then followed by any losses, then any possibility of increased requirement or any illness or cold stress, that we have to look into possible causes. So what will be possible interventions? Like I told you, we have to see it. Particularly, thing is late onset hyponatremia, inadequate fortification, uh, for milk feeding means they are frequently changing the breast in between. So these are common causes, or KMC not providing for much more also. Like I discussed previously, KMC also has a dose dependent actions. More the KMC hour, more will be benefits. So in a practical day-to-day life, how we can have a nutritional plan ready. So there are different nutritional software. One is good from Kimea, and that is from KM Hospital, Umesh Vade sir. Uh, and there are different Excel for TPN calculations where if you enter the values, there will be calculation done. And one app that and Telegram also one app and Telegram group also by Dr. Venkat, our senior from Hyderabad. So that is also good handy to prepare daily TPN volumes and enter volume sheets. So, uh, so this is a nutritional bundle, means summarizing all point: early aggressive total parental nutrition. So on first drip is amino acid drip, then the adequate protein and lipid provision, then weaning starting at least 50 ml per kg, then continuing till 100 ml per kg. This aggressive TPN followed by enteral nutrition, colostrum on day one itself. Then we have to come out of fear of rapid progression of feed. Then fortification at timely interval and kangaroo mother care. So these will be our nutrition bundle. So these are three component of our bundle. So kangaroo mother care, there is this is no need to talk more the KMC hour, more will be the breastfeeding rates at 3 months evidence wise. So what will be the ideal nutrition plan? So if the preterm mother is likely to deliver, like if the baby is twin or previous LSCS, or if there is a PIH mother. So high risk mother, it is if the mother is likely to deliver preterm, we can have a antenatal counseling regarding mother own milk and how we can start lactation early. So early parental nutrition, then early expression of mother milk, then lactation counselor dedicated for NICU mothers. So they can initiate lactation, handle the common lactation issues. Then we have to ensure daily expression, at least 8 per day, and night expressions including. So use of breast pump in initial week, followed by no need of breast pump, but initial first week it will help, particularly hospital grade. If we are catering for mostly high risk infants, particularly ELW and BLW, then infant care practices where mother is part of, like kangaroo mother care, non-nutritive sucking, or motor stimulation. And then we have to understand this concept, mother own milk as a medicine. So we have to write daily. So like a surfactant we had given at this hours of after birth, early rescue surfactant. Similarly, mother own milk colostrum received within 1 hour, 2 hour after birth. Then daily mother own milk intake received by the baby, as it has a dose dependent action. And identify true feed intolerance. And if the baby is on minimal enteral nutrition, and there is no clinical background scenario at risk of NAC, there is no need to frequent change and rapid advancement of feed and timely fortification. So this was my dashboard in my unit where I worked and done my neonatology. This was our board and lactation sisters. We were used to provide this hospital carried pump, and we had this mother leaflet where what is the role of mother from day one till first week till the NICU stay. And we used to celebrate the healthcare worker, that may be a lactation nurse, that may be a sister, or that may be doctor, or any ward boy also, who motivated and try to get them milk. So this may be relevant, may not be relevant to every setup, but ideas can be different in a different scenario. So the message is, we have to have a mindset that preterm birth, particularly extreme low birth weight, is a nutritional emergency. We have to have a nutritional plan beforehand, and we should have a nutritional dashboard where so depicting to everybody. So with this, I would like to conclude my talk. Ashish sir.
Thank you so much, Dr. Dattatray. I think it was a very in-depth and detailed description of preterm nutrition. And you also talked about the total parenteral nutrition and how you can supplement lipids, amino acids, and different available like amino acid preparations and lipid preparations, and also about the glucose. So it was a wonderful talk. Thank you so much. And you have also discussed a lot of controversies which come with enteral nutrition. And so you've cleared most of the doubts regarding enteral nutrition. So I just had a few questions. So any, like, if there is a resource limited setting, so can they go ahead with total parenteral nutrition if they get a very premature baby? So in case they don't have a laminar flow or other things going on, so can they still use parenteral nutrition, or how should they tackle this situation?
So I am also working in resource limited setting presently at Latur. So where it is difficult to get central lines, PICC lines, because it is costly. So one PICC line cost about around 8,000. So in that peripheral IV cannula, so water lipid emulsion available, it has a osmolarity almost 300. So safely 1 gram per kg we can from itself, and result in thrombocytopenia or sepsis. So it is absolutely safe to provide a lipid infusion. Amino acid, amino when easily available, 2 gram per kg we can start. So 2 gram per kg amino acid, 1 gram per kg lipid. And in resource limited setting, we should have invest, get the mother own milk. So enteral nutrition we have to rely on more. So try to get the try to solve the initial lactation issues, and frequent expression, try to get the mother own milk. So that is the only way out. So with minimal nutrition and based on the glucose level 6 to 8 mg of GIR infusion, and what I said, we can safely go up to 2 to 3 gram of lipid and 2 to 4 gram of amino acid from peripheral cannula. So there may be frequent changes of IV cannula, but if the baby is getting it, getting the optimal nutrition, it may help in a long way. Like there may be lesser BPD, lesser ventilation needed. So growth will be that will be helpful in a long way. And meanwhile, we can prepare for enteral nutrition. That is a only feasible way out in a research limited setting.
True. So maybe focus more on getting up the enteral nutrition faster, and then total parental nutrition.
Yes.
And I had one more question. You also talked about the multivitamin infusion. So MVI, they are not available currently in India. So what are you using for MVI? And also about the trace elements, like how do you tackle with that?
So trace element not needed for every baby. It's a baby to baby. So the baby is needed more than 1 week of enteral nutrition. And if there is a background clinical scenario like NAC, baby is unlikely on full feed. So we need to give the trace element. So salicil is easily available, and this we can start if the baby is likely to be on total parental nutrition by 2 weeks. We can start. Not every baby needed trace element.
Right. Okay, so I don't see any questions in the chat box. Anyone from the participants wants to ask any questions to Dr. Dattatray, he'll be very happy to answer. So no, so I don't see any questions coming. Okay.
So there are questions with what are the Nutan Verma sir? What are the challenges or constraints of human milk banking in an institute in India? So human milk banking still it is in newborn stage, very nascent stage, but the framework and government of India is very keen, had taken keen interest in establishing human milk banking everywhere. Particularly, every medical college is likely to have a human milk established. Cost of human milk establishment is 50 lakh, and every college should have this human milk banking. Presently in Pune, there are van which are collecting donor milk, and good human milk bank working in Pune.
Yeah.
Challenges will be cost involved. Privatization, private human milk banking are still not there in India. Challenges are mostly cost content and quality of like in blood bank, the quality of this blood. So checking of infections. This is the second challenge. So the question answer to the question is, challenges are, first is cost, and second is keeping whatever collected donor milk safe. That means they need good pasteurizing instrument equipment, and need infrastructure. So they need one medical officer, then lactation, different staff will be there, and cold chain will be needed.
Yeah, very true. It requires manpower as well as infrastructure to have running a good human milk bank. But I think over the years, lot many institutions and like level 3 units are starting to have their own human milk bank. They're also transporting this human milk to different areas to take care of that. So with this, we'll conclude the session. And thank you, Dr. Dattatray Kulkarni, for giving us time and um, educating us on preterm nutrition. Thank you so much, sir.
Thank you. Thank you, sir.
So with this, I'll end the session. Thank you.